This is how you cross over from Israel to Gaza, and right now we're in no man's land. Prime Minister, do you now regret when once asked what your favourite joke was, you replied Nick Clegg? And Deputy Prime Minister, what do you think of that?
Mr. Trump, why should you be president? What makes you fit for the role? Is it just one big ego trip?
Thank you very much.
People aren't sure they can trust what you say. You say things and then it turns out that they're not quite what you said.
And if we deliver what we say we're going to deliver.
My name's Andy Bell and I've been a journalist for over 30 years. In this podcast series, How Did We Get Here?, I try to provide context and background to a big story in the news by talking to someone with real knowledge and expertise in the field. This week we've had a report into racism by the Commission on Race and Ethnic Disparities, and concerns have also been raised about low take-up of the COVID vaccine by the Black, Asian and minority ethnic community. So, do ethnic minorities face worse health outcomes than white people? Are they more likely to get sick, and if they do they get worse treatment? And is there institutional racism in the NHS? I've been talking to Dr. Ajwa Danso, a black GP working in London and an advocate for better health treatment for ethnic minorities. The report may have concluded race is not a key factor in health. She begs to differ. Dr. Ajwa Danso, thanks for talking to us for this edition of How Did We Get Here? Talking about issues of health in the BAME community in the UK. For a start, basic question, do you believe there is a disparity in health outcomes in the UK for people from the BAME community?
Absolutely. I see it on a almost daily basis, not just at work, but also in my own personal experiences as well. There is definitely disparities within the black population and also within Asian communities as well.
Okay, give me an example, first of all, of where you can say, right, there it is, slam dunk, absolutely clear that black people are doing worse in terms of health outcomes than white people.
I don't think we need to look really that far back. If we look at COVID, for example, black people were disproportionately affected compared with white people. And there are lots of different reasons as to why that could be, looking at various socioeconomic factors, looking at the types of roles that people had, Black people make up quite a proportion of the NHS, for example, more likely to have public-facing jobs as well. So all of those things contributed. But also, when you looked at some of the backstories that have actually come out, there were reports of, at times, nurses, for example, and healthcare assistants feeling, and it was published in the nursing standards, feeling as though they were kind of being chosen and selected to work on COVID wards, for example. So they felt targeted at times. And if you look at, there's a story that's kind of, currently being looked at, Mary Ajapong, who was a nurse who was pregnant, working at her hospital. And if you look at that story and look at the things that are coming out of that, you can see clear disparities that exist. So COVID is just kind of shining a light on pre-existing health inequalities.
Those are inequalities, would you say, that are as a result of people's physical makeup, their bodies, or is it just because they are tending to be in socio and economic situations that make them more vulnerable, or does that not matter?
I think we can't ignore, as a scientist, as a medic, we can't ignore that, black Asian people are more likely to have things like diabetes, high blood pressure, which does put you more at risk. But also, I think we have to be comfortable and we shouldn't shy away from saying that racism actually plays a role. And there is racism within the NHS, and that institutional racism can facilitate some of these disparities that we see.
It's interesting that you use the phrase institutional racism with regard to the NHS. We're talking today on the day that the Commission on Race and Ethnic Disparities has published their report. Among other things, they say institutional racism, they found no evidence for that. And that will be chewed over a lot. But I want to specifically talk to you about what they say about health outcomes, where they say they reject the common view that ethnic minorities have universally worse health outcomes compared with white people. That is the conclusion of their report. What do you say to that?
I'm really shocked by that, and I'm really disappointed in that. I think a lot of work has gone into showing these disparities, and I think half of the reasons why we have these disparities is that people are not willing to acknowledge the issues that exist. If you look at the 2020 report, Black People, Racism and Human Rights, produced by the Joint Committee on Human Rights of the House of Commons and House of Lords, it stated in there quite clearly that racism was a factor and the disparities did exist. So this kind of just goes completely against that. That was not too long ago published. So I think it's really disappointing. I think that it illustrates the issue that is at hand. Half of the issue is that we have to acknowledge these disparities in order to be able to kind of ensure that there is equity within the health system.
I suppose maybe we should look at the word they say have universally worse health outcomes. Is that their way of not coming to the same conclusion as you? Do you think that, I mean, clearly in any group there are going to be people doing better than others. Is that the way they say, look, you can't put this down to a disparity as a result of race?
I think that illustrates another issue, actually. Universally, there's a danger of categorising Black, Asian, other minority ethnic groups, because really and truly the risks are completely different. And I know you mentioned, maternal health, and that's something that's been looked at more recently. If you look at the disparities, yes, there are disparities within BAME, a term which I think is also very problematic for reasons that we've already touched on. But if you look at within that, Asian women are twice as likely to have to die in childbirth, and if you look at mixed race people, 3 times. But if you look at Black people, 5 times more likely. Both of these disparities are shocking, but it's completely different, and it's really just highlighting the danger of putting all of those categories together and saying universally, it almost seems as though it's universally everything's fine. It is not fine. It is not okay.
Coming back to you were talking about the maternal mortality figures. Again, the Commission on Race and Ethnic Disparities report today says this is often brought up. They say, but attention should be drawn to the small number of people involved. Now, obviously, this is awful for anyone whose family this happens to, but they say the number for Black women dying in these circumstances, 34 out of 100,000, and they say clearly their implication is these numbers are very, very small, and it's quite hard to draw bigger conclusions from them. What would you say? I
would say to that the numbers may seem small, but the numbers don't include morbidity. So we're not looking at the people that are having long-term sequelae as a result of complications during childbirth. We're looking at the people that have died, but there are many women that have had complications that are still living with those complications, and we're not looking at those numbers. And interestingly, if it wasn't an issue, we wouldn't have campaigns, we wouldn't have media coverage about it. It's a shocking statistic. And even more recently, the Royal College of Obstetricians and Gynecologists have actually set up a specific task force with the aim of changing those statistics as well. And they're working with organisations such as 5 Times More, which is spearheaded by 2 Black women who are working so hard to change those narratives. So it's quite dismissive to say that it's a small number, because it affects so many Black people within our community.
I want to just say a bit more about the report that we've had out today, because it is such a significant piece of work, and lots of people are talking about it. I mean, they also say life expectancy is not worse. What do you make of that?
It almost feels as though we're trying to kind of support this idea and kind of pick through the points that suit a specific narrative. And I just don't think it's very helpful. I think there are so many major issues that have been produced, so many statistics, so much data that's been collected. We can't just dismiss all of those things with other factors. Yes, life expectancy may well be the same, but the quality of life, what about the quality of life? That's something that we need to really look at. So I haven't, as I said to you, the report I haven't looked at it in full, but looking at the chunks that I've seen, it can it can appear a little bit condescending and a little bit dismissive.
Okay, well, let me ask you about something that you wrote. You've written an article for the Future Healthcare Journal, and in that you said racial bias is systemic. Now, did you mean that in the NHS, in the health system? What exactly did you mean? You said racial bias is systemic, which is a big claim. Let's be frank.
It's a big claim. It is a big claim, but it's something that I really do believe, and I think it is systemic within the health system. And it's not just patients. There is an issue even with medical school itself, even with the application system, even with the training. I mean, I've spoken about the issues that I've had as a trainee. Having microaggressions in the workplace coming from other well-respected trainers. I was asked about my thoughts on whether the Negro population are genetically predisposed to smoking cannabis, which I thought was completely inappropriate. But at the time, I didn't say anything, nor did any of my white trainee colleagues. They didn't say anything. So there is an issue internally that's much more, that's so deep rooted as well. And interestingly, when the concerns are brought up, at times you are dismissed. At times you're told to just get on with it. And it's really very, very, very difficult. And also, if you look at the training as well, when you look at, as a GP, I see lots of different skin conditions. But when you go on something like NHS UK and you have a look at skin conditions, there are next to no pictures of skin conditions on black or brown skin. So there is something to be said about that. It's taken a medical student by the name of Malone to publish a handbook looking at clinical signs of on black and brown skin. Why has it taken that to address the issues that exist within our training?
Do you think that racist assumptions, you've used that phrase, you talked about it, you used the word racial bias as being systemic, that racist assumptions within the NHS ends up meaning BAME people get worse outcomes and get worse treatment?
Absolutely, and I stand by that, because it's not just it is systemic. We see it. We see the repercussions. As a black GP, the number of times I have black patients that will want me to advocate for them. You hear of relatives that are being dismissed in A&E until I also hold a certain amount of privilege as a black healthcare professional. I am able to advocate, but also at times, being black, I'm not able to advocate as I would, because that is just something that's there. And if you speak to black and Asian colleagues, they will say similar. There are microaggressions on almost a daily basis that you have to face. So it is systemic, and I really do stand by that.
When you say advocate, you mean, say there's a member of the family who says, I believe my son, daughter, father is really sick, and they're not taken seriously?
Absolutely. So, going into hospital, saying that they're very unwell, may be discharged earlier, may not receive the treatment that they deserve. I've had to actually, in my own personal family, I've had to step in and say, actually, no, we shouldn't be discharging because these results show this. And then things are taken more seriously. But it shouldn't have to happen like that. People should get the same and fair treatment as anybody else would. So that's the issue. And as I said, I run a social media platform, and the idea behind that and the clinic diaries is to try and speak about what you should expect, how you should try and advocate for yourself as a black or ethnic minority individual.
Is this part of the reason why there has been lower take-up of the COVID vaccine, especially black communities? It's partly because of experience of the system?
There's a large distrust within the community for some of the reasons we've discussed, but also some of the actions of the government. So if you go back to last year, it was very clear very quickly that black and Asian people were more likely to have worse outcomes with COVID. But when we looked at the prioritisation of the vaccination schedule, there was no mention of ethnicity. So it's kind of giving very mixed messages, and people don't know how to take that information. Plus, with all the sort of myths and everything coming out, it's a cycle within the Black community. It circulates because they do not know how to trust, and they don't know who to trust. And we don't, as I said, we don't have to look very far back in history to look at why that is. And we need to look at why that is so that we can actually change those statistics.
Is it a suspicion specifically about the health service, or is it does it get fed into from sort of broader suspicion of public bodies, government authority? What is it? I think it's definitely the health system, but I think it's other systems as well. We know that there are, inequalities within the judicial system, within the education system. It's not just the health system. So it kind of breeds this feeling of distrust as well. And there's lots of other little things as well. So when we look at, the media and then looking at stories when we had the first people having their vaccines, it was a really pivotal moment. But when you looked at the TV, there were not many Black people as well. So that kind of feeds into it again. Sorry to interrupt, but that could have just been the way the pictures were. I mean, it's not suggesting that anyone was being discriminated against at that point in terms of the vaccine being given.
I think it played a part. If you look at the pictures when we were clapping for NHS heroes, not many of them shown on media in the very early days were Black or Asian. So it's also, it's important to show the representation that exists within the NHS, also the representation of those that have actually taken up the trials as well, because actually looking at some of the trials we had quite good numbers and good representation of Black and Asian people, and that is something that was important, and that is important because if you explore the fears that people have about why they don't want the vaccine, that sometimes people will say well, I don't think there's been enough evidence, we don't know what it's like with Black people, we don't know, but actually we do know because they were, we were represented fairly well in the trials.
But nevertheless, the suspicion remains because it's just it's a bigger issue than it predates COVID.
It's a bigger issue, and it's not just a recent thing. This is decades, centuries of at times maltreatment.
Just to go back to, we were talking about this phrase or label BAME, and the Commission report does say they don't think it's helpful. Do you think it's helpful in terms of trying to work out health outcomes for people?
No, I think it's a term that I've disliked for a long time. I think it's great that we're moving away from the term. And as I said, I gave you the example with maternal health. It's not helpful to group people who are completely different together. And it's just not safe. And also, if you look at the COVID statistics, yes, BAME have worse outcomes, but actually Black African people have the worst outcomes. So you can actually, if you break up the data, you're able to tackle those individual communities more specifically as well.
So would you scrap it tomorrow if it was up to you?
I've scrapped it from my vocabulary a long time ago.
Okay, fair enough. You've already mentioned some of your personal experience. I mean, what about when you're working as a GP? What are the sort of things that people come to you with as your patients, where you feel they're clearly getting a rough deal, or they're not getting the help and the treatment that you would feel that, say, a white person would be getting?
Oh, it varies. I can think, often because I am the only Black female GP in my practice, I do have a lot of Black patients because they feel that they can relate to me for various reasons. There's lots of examples, and I think a lot about gynecology, actually. That's the one thing that springs to mind, because often it's hard to communicate your feelings because it's such an intimate area. People often feel very comfortable to speak with me. And at times, it's just having the time to explain a procedure. So, for example, Black African people are more likely to have fibroids, which causes lots of heavy, painful periods. And often, one of the options is hysterectomy, but it's a very, 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 it's one of the last resorts. But at times they feel that that's the only resort because of whatever reason it could be. But having the time to actually to speak to them and discuss the options rather than being told actually you're just more suitable for hysterectomy is a way that, again, patients don't feel that they can advocate for themselves.
Could that just not be more of a female thing rather than an ethnicity thing?
It may well be, but some of these patients have seen ethnic minority women or female gynecologists, so it's not necessarily gender related.
Okay, they're not feeling more comfortable simply because they're talking to you as a woman. You feel that it's also because you're a black woman talking to them.
Definitely. I mean, even when we come and think about the vaccine, there's lots of information there at the moment, but patients will still ask me. I mean, I've been quite lucky to have worked at the COVID Hub Centre, and I've had black patients who will pull me aside and say, "Doc, what's really in the vaccine? What's really in it? Which one do you think's better?" Like almost as though I have some sort of inside information, but it's just not the case. But they trust me, and I respect that, and also I understand where their distrust comes from. So that's why they feel that they can ask those questions.
Do you feel we've made any progress in the time that it's a relatively short time for you being a GP, but even in the time that you've been inside the NHS and worrying about these things, do you feel we've made any progress?
I think we have made some progress in the sense that we are having these conversations. People feel that they can speak about these issues, because it is at times brushed off as that's just how it is. When I speak to some of my colleagues who are much more senior from ethnic minority backgrounds, they just say, well, we just get on with it. Patients are sometimes racist. We just get on with it. But it's just not acceptable. And I think we have to continue these conversations, but also we need to push for change. And we've had lots of reports, lots of studies, lots of it's there. We need to actually implement some of these things. And like you said, are we having change? Yes, we are, because we are seeing some of the Royal College of Obstetricians and Gynecologists and the Royal College of GPs. They're all trying to implement change in various ways.
And what's working? What would you say? That was good. That was a good idea, and it's worked.
That's a good question. I think I think maternal health, we have seen a lot of progress. We are, a specific task force to look at these statistics and actually implement change is what we need. And I don't want to, almost applaud them, because this should have happened. This is what should happen. But it's good to see that it's being taken seriously.
Okay, I have one more question, which I should have asked earlier, but I'm going to ask it now, which is, again, from the report that we got today, that they see no evidence of racism in the treatment of mental health conditions. What do you think of that?
I feel that that's just not helpful at all, and we know it's not the case. Black people are more likely to be sectioned, more likely to be diagnosed with a psychotic disorder. So I just think that we've taken 2, 3, 4 massive steps backwards, and it's just a really unhelpful statistic. And it kind of just takes away from all the hard work and the data and the statistics that people have tried so hard to put into the public domain.
I mean, again, from trying to see from where they're coming from, there may be mistakes, there may be misunderstandings, I suppose these are my words, but no evidence of racism. Can you see how they might have got to that? I
don't see how they could have got to that. I really don't. I don't, because you're just not acknowledging that people also have racial bias. Like it's subconscious. So to even say that, you're just basically taking away from what we already know. So I can't see how that's possible. But yeah, it's disappointing. Do you
feel optimistic? Do you feel like we are getting somewhere, or not?
I do feel optimistic. I'm an optimistic person, but I do feel optimistic because I know there are lots of people who are working so hard to have these conversations, to get people talking, to get people thinking, and to implement change. So I'm optimistic. These conversations have been happening for some of us for a long time, but for others, maybe in the last year. But we're still having those conversations. So that's a really positive thing to take away.
Dr. Ajwa Danso, thanks very much for talking to us.
Thank you.
Dr. Ajwa Danso, shocked by the official conclusion on racism and health this week. If you have thoughts on this or ideas for other podcasts, you can email me at andy.bell@itn.co.uk, and I'm tweeting at @andybell5news. and please share, rate and review. Thank you for listening to this edition of How Did We Get Here? There'll be another along soon.